Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much anything else we have which is of infectious disease or infection prevention nature. This is the week of October 16th. Yes, October is here already, hard to believe. Hopefully, parts of the world tuning in that are not Arizona are experiencing some fall-like temperatures. Here in Arizona, we're still hitting 100 degrees, so you would like to think that would put a halt on any respiratory viruses, but that is not true at all. As we'll hear about today, a lot of our questions have to do about RSV and influenza and other things like that. Other than that, in the emergency departments, we are in fact seeing plenty of respiratory viruses, still the occasional gastroenteritis virus, and a whole bunch of everything else in between as well. So with that, to our questions, and specifically to RSV, with RSV cases on the rise, do I have any tips when it comes to preventing the spread of that virus within a practice or a hospital setting? Yeah, fantastic question, and this is an annual question that comes up when we are in a typical RSV season, meaning that RSV cases increase in the community. Of course, it is likely that they can and will be imported into the practice setting. Obviously, sick visits need to be sick visits, and healthy kids need to be kept separated from that, and the challenge is how to do that. A couple tips that have been found to be useful and practiced, quite honestly, during the early days of the COVID pandemic, and that is if one has the potential to see acute care or sick visits in the ambulatory practice setting, to batch those at the end of the day, which of course is, when parents are like, oh my gosh, my patient or my child has got something brewing and I can hopefully get off work a bit early to bring them in, that would be an ideal time. The key is, of course, to try and have the healthy preventative routine pediatric visits in the first part of the day, and then have the opportunity for the waiting room and the examination rooms to host sick visits in the late afternoon, and most importantly, to have time overnight for air exchanges from the usual air handling system. No, we don't need HEPA filters necessarily. All we need is air exchanges just to vent that air from inside the practice setting outside. And honestly, in a normal non-operating room theater, just a normal office space, that takes at most an hour or so. So we're really talking an abundance of caution in the practice setting. Of course, in a patient who is having respiratory symptoms, should it be RSV or even some of the other respiratory viruses like rhino/enterovirus, those are largely spread by respiratory droplets. Those little spittles which can project from the patient with a cough or sneeze or a runny nose about 3 meters and land on horizontal surfaces. So, doing maybe not a terminal clean, but wiping down the table, the computer keyboard, the examining table, etc., the regular routine cleaner is going to be fine. Depending on which product your clinics use, even a 10% bleach solution is more than adequate. Certainly works for everything else in the clinical setting. Wiping down the exam rooms between sick visits, batching them or cohorting them at the end of the day, and then just ensuring the clinic has time to air out before the next day's healthy routine preventative care visits. That would be in the ambulatory setting. Of course, masks for everybody, gowns. It would be ideal if we could afford gowns and gloves for every single sick visit, but realistically, wearing a mask and very good hand hygiene by every person into and out of that sick visit room is going to be very important. The hospital. In the hospital, we have sort of two different areas in which we think about this. One would be the pediatric ward, pediatric intensive care unit, where, of course, patients are being admitted because they are sick, and routine hospital infection prevention practices apply there. The neonatal ICU is the other big one, and here we're talking a very dense population of highly at-risk patients, i.e. premature and or very sick term infants hospitalized who really have not much immune system to speak of to defend them. So in this case, we take what is felt by some to be draconian steps, and that is to prevent health visits by siblings under age 12 into, and this is just a routine cutoff of kids older than 12 who can reliably cover the cough, wear a mask, wash their hands, but any child under age 12 years is prevented from entering or visiting a sibling hospitalized in the neonatal ICU. And of course, any child, any pediatric patient, anybody, period, who has symptoms of illness should not be visiting anybody in the hospital at all. And that's just good routine infection prevention practices. So the real question, of course, is when to take that step of preventing visits by the pediatric patients to the NICU. And what has been used successfully in the past is to look at local epidemiologic trends, which are available either from the county health department and or the state health department. Here in Arizona, now 4 weeks ago, we received a health alert by the Arizona Department of Health Services, which had been tracking RSV cases and RSV hospitalizations and had documented 3 weeks in a row of increases for both of those. So that is a really good indicator of increasing burden of RSV in the community when you start to see an increase in hospitalizations reliably over 3 weeks. So that reasonably could be your take as well as to when to pull the trigger and to prevent further visits. When to stop that, of course, is when those same 3 weeks of trends are downtrending or even 3 weeks of having no RSV hospitalizations. That's not likely, quite honestly, because there can and are RSV cases throughout the year. It is not a completely quiescent season in between the winter months. But reasonably, when one goes several days without an RSV admission, that is when one can take off their restrictions. So there you go. It's mostly about making reasonable epidemiologic decisions on when to prevent visits in the hospital setting and cohorting sick visits in the ambulatory setting with really extremely careful hand hygiene and mask wearing for everybody included at all stages. All right, thank you for that question. Next one, what do I know about the combination PCR home collection kit for influenza A and B, COVID-19, and RSV? Well, there is one such FDA-approved home collection test. It is available through LabCorp as an on-demand, meaning that the patient can request a delivery of a testing kit from LabCorp or directly from the manufacturer. It does not need a prescription, and it is a multiplex RT-PCR, meaning reverse transcriptase PCR, to detect the RNA of those viruses. So again, influenza A, influenza B, SARS coronavirus 2, and respiratory syncytial virus. Now, this is not a do it at home, meaning the actual result is not available at home, but the kit includes the collection devices, which adults obviously can test themselves. Teenagers could probably figure it out, but everybody else is getting swabbed by their parent. Putting the swabs into the kit and sending it back to LabCorp, where the turnaround time is reported to be 2 to sometimes 3 days. Now, it is a PCR assay, very likely, depending on volume, that either the local LabCorp or the central LabCorp in your practice region is batching those tests and running them once a day, although it may be more frequent, especially as volume increases. In terms of sensitivity and specificity, it's a PCR assay, so quite specific. The RNA primers detect only the RNA which is there. Sensitivity really depends on the patient, both in terms of how adequate is the specimen. So simply, doing the nasal swab around the external nares is not enough. You got to get good and juicy, just like we're all used to doing with our at-home COVID tests. So make the eyes water, think that you're penetrating the brain. Don't go too far, because that has happened. So we need a good specimen, and especially we need respiratory epithelia from the deep nares. That is where the viruses are attaching. That is where they will be detected by presence of their RNA. So sensitivity in large part depends on the collection technique, but it also depends on where in the stage of their illness the patient is. So very early days, they may not have a huge amount of viral expression depending on the virus. Certainly, if they've been sick for more than a week, that same viral expression may also have started to lower. So the patient who's been sick for 2 days or so is probably right in the middle of extreme symptoms. That is the patient who will have the most sensitive result. On the other hand, you don't want to wait too long, because why else do the test, especially if one can provide treatment, i.e. treatment for influenza A, if that is what they have, or Paxlovid for SARS coronavirus 2. So it's sort of a balancing act. I think in practice, and the early sensitivity assays were all done on patients who self-identified as being sick with an upper respiratory tract illness for at least 1 or 2 days, having the kit on hand, so on day 2, swabbing themselves, sending it in. And in those situations, the sensitivity and specificity of the test are really quite excellent. So that's as much as we know. It's the only approved test for at-home collection. The processing is done back at a LabCorp central processing center, and the actual results are quite good, assuming the specimen collection is excellent. All right, next question. What are the thoughts on mixing and matching COVID-19 vaccine boosters? Is there any evidence proving this has a higher immune response? Well, so we have to know what we're talking about in this situation. So currently available FDA approved and in pediatrics FDA emergency use authorized approved are just 3 products in the United States. Those being the 2 messenger RNA booster vaccines, or vaccines I should say, from Pfizer and Moderna, and the Novavax vaccine, which is the nanoparticle bonded vaccine. So each of those has their independent indications. Certainly pediatric patients ages 6 months and up can and should be vaccinated with these newly created, newly approved products. Specifically, Pfizer and Moderna are the preferred ones in pediatrics world. And these new vaccines are all antigenically focused on the XBB.1.5, which has so far very good cross protection for even the newer circulating subvariants of the Omicron SARS-CoV-2, which is out there. That is pretty much the one vaccine which is available unless you have some of the older vaccines still in your office space. So mixing and matching those probably does not convey much of a benefit. An mRNA vaccine is an mRNA vaccine. On its website, CDC advises against mixing and matching if at all possible. However, for very understandable financial reasons, it may be that your practice space is only purchasing the Pfizer product, for example, and you may have patients who previously got their primary series with the Moderna. In those cases, it's absolutely fine to go ahead and boost with the Pfizer if you don't have the Moderna around it, and vice versa. So there isn't any real treatment advantage to that. It's just simply a different platform, which, again, the antigenic structure may be slightly different, but it is not likely to create much of a boost other than the boost you're already getting with a repeat mRNA vaccine. Interestingly, however, in the earlier days of vaccine discovery for SARS-CoV-2, there was it's not even a phenomenon, a finding called heterologous booster phenomenon, which again, it's in the name, it's not phenomenous at all. It's based on good science. And that is, if you can trigger an immunologic response by different vaccine products, different ways of triggering that immune response, that is going to recruit different populations of T and B lymphocytes and thus broaden and deepen the pool of immunoreactive response that patient has. For example, a patient who somewhere else, or maybe here in the States in the early days, received one of the adenovirus live attenuated vaccines and then was boosted with mRNA. Those 2 different types of vaccination were going to harness and recruit different immune responses, still the same overall adaptive immunity, but with different cohorts or different cell lines of T and then B lymphocytes. And so one immortalizes different B cell or B lymphocyte memory cells, which will both create antibodies to slightly different components of the spike protein. So there, the heterologous approach or different approach to immunization actually did create an additive effect for immune response. However, that response, if present between the 2 mRNA products, is not likely to be a significant addition, but certainly a very good deep way of vaccinating successfully the patient. And also, the current mRNA vaccines are so robust in creating immune response, either as a booster or still as a primary series, that there isn't much need for adding to that by the heterologous approach. Not yet tested would be any differences between Novavax vaccine, the nanoparticle vaccine, and the mRNA vaccine. It stands to reason, again, different ways of triggering the immune response, that one would see that same response. But as yet, I have not seen published or peer-reviewed data looking at that in any meaningful way. So, great question. The overall answer with all of that scientific mumbly bump is that there is no evidence of a higher immune response between the two mRNA vaccine products. And then final question, have I seen an increase in mosquito-borne illnesses, specifically dengue? So yeah, thank you for that question. You would think, gosh, it's fall, we should not be seeing mosquitoes. Yeah, well, at least in Arizona, and if there are others of you from the southeast part of the United States, yeah, we still see mosquitoes, and we still have mosquito bites. So it is an important and a very valid question, certainly for the remainder of this season and upcoming. So at the basis of this question is the fact that the Aedes albopictus and the Aedes aegypti mosquito, which is the known carrier, the known vector for dengue virus, chikungunya, and Zika virus. That mosquito is prevalent in the southern states of the United States, and certainly in Mexico, and then further down into Central and South America. As cases continue to be quite prevalent in South America and now Central America, they increasingly have become prevalent in Mexico. We've known this for quite some time, and it is only a matter of time when the mosquitoes in the United States, and here I'm thinking specifically the border states, are going to become infected with and sustain presence of at least one, if not all three of those viruses I just named. Here in Arizona, Phoenix, we've had our first native case of dengue, meaning a patient who had no travel history and could only have been exposed by a local Aedes mosquito that itself had dengue in it, which makes sense. If there was an imported case, that mosquito took a blood meal and then shortly after, within its lifespan, either propagated and or took a blood meal from that patient with the native case. So it is already happening, now obviously tiny numbers, but the future is that this will continue to occur increasingly, especially as we continue to have warming of this part of the world. Yeah, well, the entire world is warming, but we will continue to see, I think, increasing numbers of mosquitoes, and every expectation is that will be followed by an increase in cases of dengue, chikungunya, and Zika. And it doesn't stop there. Of course, we are already having every year a robust season with West Nile virus, with the Culex mosquito, and we're now seeing native cases of malaria, meaning, again, individuals with no travel history, no importation of malaria. So far in Florida, Texas, Georgia, and most recently in Washington, D.C., or actually I should say Maryland, but I would travel to D.C., and with, unfortunately, Plasmodium falciparum, which is the worst of the worst for the 5 strains of malaria that we know about. So, yeah, mosquito-associated diseases in general are on the rise. It's not an explosion, but it is for the foreseeable future, a continued increase. And we can expect to see increasing numbers of patients either with or at risk for all mosquito-associated diseases. So if you haven't already, and certainly I can handle this in a subsequent podcast, it is time to educate yourself about the appearance of those mosquito-associated illnesses. I will say, just by brief introduction, for dengue and chikungunya, typically starting as your average flu-like illness, but with severe myalgias and then very severe polyarthralgias. Dengue is called breakbone fever for a reason. Patients with a first, second, or even, heavens forbid, third episode of dengue swear that their bones are breaking because they hurt so badly. Chikungunya, which comes to us from the Swahili for that which bends up, similarly, patients with very severe, typically peripheral arthralgias, and so almost impossible to walk or use their hands because the small joints of the hands and feet are excruciatingly painful. Chikungunya is unfortunate because there's a chronic relapsing form which can last for months. So the impact on school for our patient population and for work for adults is extreme. In parts of the world where there's a lot of chikungunya, there are patients who are immobilized from that virus infection, and they have no resources with which to get back to a normal, healthy life until or if that virus recedes. Zika, I think we all know from the horrifying images from Rio de Janeiro and the multiple cases of extreme microcephaly in babies born to mothers with Zika. But Zika virus infection by itself, if you put aside for a moment the congenital aspects, the infection is much milder than dengue and chikungunya. So still, fever, headache, myalgias, rash, and the myalgias sometimes also participate with polyarthralgia, so again, a peripheral small joint phenomenon, but much milder in all regards, including the fevers, and typically patients are sick for 3 to 5 days or so, maybe with a chronic fatigue tail off in some cases. The bigger concern with Zika, of course, for our patients are the potential babies born to mothers with Zika virus at some point in the pregnancy and being delivered with extreme microcephaly and all of the cognitive dysfunction which you can imagine subsequent to that. So that would be those three viral infections. Malaria, oh boy, major list of manifestations, but fevers, severe headaches, nausea, vomiting in some cases, just extreme lassitude, and the fevers can be quite prominent. And then similarly with West Nile virus, again, flu-like illness, followed by, in about 10 to maybe 15% of the cases, a central nervous system component, meaning evidence of encephalopathy. In pediatric patients, many of our patients presented with a Guillain-Barré-like presentation, so sort of an ascending paralysis, differing either hypo or areflexia, and in some cases urinary retention. So that is what is out there, and we can certainly anticipate increasing cases as we go forward. Not surprisingly, certainly in Arizona, the state lab has testing in place, and it's a simple matter of coordinating a suspect case with your county health officer, sending the laboratory specimen to the state lab, and then getting results back shortly. For things like West Nile virus, of course, we have access to serologies through hospitals and certainly commercially. And for malaria, many cases actually malaria picked up by the hematology technician who's doing the peripheral smear of a complete blood count. Like, oh, hey, wow, we're seeing some erythrocytes with some internal stuff. So one can also do a rapid antigen test for the various forms of malaria, and that is available as just a blood dot test. So that, in a very brief nutshell, is what I think we can anticipate coming to us. Currently, however, our bigger concern is the rising RSV season and the trifecta of RSV, influenza A/B, and SARS coronavirus 2. Yep, every projection is it'll be another interesting winter. Hopefully nowhere near as severe as we've experienced for the last several, but all bets are off in terms of predictive modeling. Some parts of the country have seen a plateauing of the recent mini surge of COVID-19. Others are still seeing cases coming in hospital, and certainly RSV is making its presence increasingly known. So hang in there, folks. Thank you, as always, for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona and other infectious diseases, or to learn how to become a member, please visit us at AzAAP.org. And in the meantime, and as always, keep those questions coming, hang in there, wash those hands, and thank all of you for your service.